going to put on offer and the methodology that we're going to use, which is a thing called a breakthrough series collaborative. Now, I know some of you will be very familiar with this methodology because you will have used it already in either internal hospital programs or you might have joined some kind of national programs around it. But I'm just going to start by explaining exactly what it is and how it works. So Nick, next slide, please. So the Breakthrough Series Collaborative was invented by the Institute for Healthcare Improvement from the States, often known as the IHI. It's a way of doing quality improvement across multiple sites. It can be done within a single nation or even across multiple nations, and it's proved to be both a popular way of kind of improving, getting improvement going, but also really helpful way of kind of making us sure that we've got a focused effort going on for a particular kind of condition such as JIA. So it's centred around 3 learning events with action periods in between to accelerate learning and improvement. It's based on a philosophy that everybody that comes into the collaborative will both learn from others and will teach others. So it's about sharing excellence, sharing lessons from success, sharing lessons from failure. And together we work to agree an aim and also a change package, a few ideas of things that we think are going to be the biggest ticket items to change. So next slide, please. So this is just the methodology that sits underneath the Breakthrough Series Collaborative. So at the launch event, we agree our aim and the areas we're going to work on together. Afterwards, in each intervening action period, each local team takes that idea back and starts to test it in their own area. And we use the simplest of QI methodology here, which is called the model for improvement, which is basically a plan, do, study, act cycle that I'm sure many of you will have used already. So then you can test those changes in your local situation and learn what kind of matters, what works and what makes a difference in your own setting. And during these action periods, you'll get access to a qualified improvement coach to offer you ongoing support, because inevitably you'll come across barriers to change. There'll be things that will be difficult, and that's where having access to an external coach could be really useful. So each team will collect some data and we'll capture our learning about how we go, and then at the next event there's time for each team to present back about what they've done and how they've learned it, what's worked, what hasn't, and so together we all accelerate improvement. And because we're working so strongly together as a collaborative, there's also a way of doing things once and sharing across. So that way we become a bit more efficient and effective too. Next slide, please, Nick. This is what it looks like in a picture. So we start off here, learning session 1, then we have the activity period to learning session 2, and again another activity period, and then learning session 3, and then we get into the final period, which is all about evaluation. So next slide, please. The 3 learning events are going to happen starting September. The first one's going to be down in Brighton, and then the other 2 are going to be in other places across the country in locations we haven't determined yet, because we will try and look at which teams have joined and how to make that most efficient in terms of logistics. Next slide, please. So at the end of the whole process, which we are aiming to be an 18-month period from start to finish, we will evaluate on what we've learnt together as a collaborative. We'll reflect on the process of working together in this way. We'll aim to share our results with other JIA centres to make sure that it's not just the 6 teams that are involved in the collaborative that benefit from this, but we can reach out to the wider organisation. And we'll co-create some opportunities for publication, and we'll also support the teams that have been involved to think about what they could do both in their locality and in their region and maybe across their system to improve outcomes for JIA. So that's it in a nutshell, and I'm going to hand over now on the next slide to Dr. Flora Macaulay, who's the consultant paediatric rheumatologist at the Great North Children's Hospital. And for those of you that love a good read, this is the signpost to the white paper that the IHI have done on this methodology, so you could go and learn a little bit more. So thanks everybody, and over to Flora.
Thank you, Anna. Can we go to the next slide, please? So plan is, now that you're all entirely expert in QI methodologies, I'm going to talk a little bit more specifically about quality improvement in JIA, and then Gavin's going to take over and talk even more specifically about what's on offer with the JIA Learn collaborative. So next slide, please, Nick. Thank you. So what we know very well as people that work in the health service is that healthcare systems comprise a really complex network of different kind of care pathways and processes. There's very significant variation between different teams in my hospital, between different hospitals, and in fact, between the 4 nations of our country. And it's this variation that makes it quite difficult for us to understand how quality of care might vary between providers, and also for us to learn from our colleagues across the country. Next slide, please, Nick. When we think about a markedly heterogeneous condition or group of conditions like JIA, these challenges become, of course, even more pronounced. Next slide, please. So, bearing all of this in mind, what do we actually know about quality of care in JIA? Well, much of our existing knowledge is derived from these 3 sources. We have a reasonable amount of information from research, and in particular from observational studies. I've already seen Leanne on the call, so there's people on this call who are super expert in these observational cohorts. Ultimately, what we've learned over the years, both in the UK and in other countries around the world, is that the disease outcomes we're finding in our everyday clinical data are nowhere near as good as the outcomes that are reported in idealised world clinical trials. Clearly, this happens all the time because we don't live in an ideal world, but there is a very significant gap between clinical trial outcomes and the observational study data we collect in JIA. This suggests, therefore, that there's room for improvement. The other place that we can look for information, of course, is in kind of big national audit data sets. Now, we don't have a big national audit data set in JIA, but what we do have are the standards of care that we all worked to develop back in 2010, and a big national audit that Helen Foster and Akila undertook a few years later. And in this audit, Helen and Akila identified quite significant delays in access to care at different centres across the country and variations in the services available. On the back of this data, many of us on this call have worked to develop a data set specific to quality of care in JIA, the CAPTCH JIA data set. And whilst we've been developing this data set, we've identified further very important differences between centres in the way their services are set up and their approaches to the collection of clinical data. So if we move on to the next slide, please. So how does what we're offering differ to what we know already? Well, clinical research is all about understanding what's possible, in other words, what we should be aiming for. Clinical audit is a little bit more about understanding what's happening precisely now. A national audit in JIA would be excellent in many ways. It's very tempting, but it would be hugely time consuming and highly expensive. This collaborative approach to improvement would allow us to kind of undertake more rapid cycles of improvement work to identify possible areas for improvement and to more quickly explore their impact. So next slide, please. Ultimately, improvement science is about reducing the gap between what's actually happening and what's possible. It allows us to iteratively examine, to understand and adapt our healthcare systems. Next slide, please. And ultimately underlying all of this is the understanding that small changes made iteratively again and again at centres can have a really big impact on services. So I'm going to hand over now to Gavin Cleary, who I'm sure you all know is a rheumatology consultant at Alderhay. Thanks, Gavin.
Thanks, Flora. Hi, everybody. So what's the big impact that we want to achieve together? So the overarching aim of this programme is that we will work together as a collaborative to improve patient-reported experiences and outcomes of care. And we want to do that within the project period up to January 2024, whilst hopefully creating and establishing a legacy to move forward beyond that. A achieving this aim, in order to achieve this aim, and has already sort of mentioned this, is that we need to establish a change package. And what that change package is essentially 3 key drivers of quality improvement. Those drivers will then be in turn informed by a series of interventions that those within the collaborative will work on, and that they will essentially undertake small and focused tests of practice change across our centres. Data is going to be really critical through in this, but I think we all recognise that that we have to make sure that collecting data is achievable and not overwhelming. So in that context, there will be a small amount of data which will be generic across all of the centres, but then individual sites working on their small and focused tests of practice will of course almost certainly need to collect specific data items relevant to that. Nick, could we move to the next slide, please? So here's perhaps just a slide that just explains and demonstrates the aim and the change package in the beginnings, the left-hand edge of a so-called driver diagram. And I'm sure some of you will be familiar with driver diagrams, some of you perhaps a little bit less so. And we're all on a little bit of a learning journey here. But here on the left is the overarching aim of the collaborative. And here are those 3 key interventions which we think will drive the quality improvement programme. And further to the right, I've not put it on the slide because I think it would just get a bit too complicated. But then further to the right, there will be a series of interventions that will inform those practices of change. Next slide, please. Nick, thank you. So what does taking part actually look like? Many of you will have come across the RCPCH learning collaboratives in diabetes and epilepsy, and I think we perhaps have a sense of just how phenomenally successful those programs are, and that's what we'd really like to replicate in paediatric rheumatology. So we want those of you who join to really feel part of something. We want sort of teams to feel that they belong to this collective. I think I mentioned this at the Glasgow meeting. I think we seem to enjoy working together. We seem to get on very well together as a community. We are super keen that the collaborative is engaged by the whole MDT, and of course that very much includes the sort of doctors in training posts as well. So what we want to do is of course sort of work together to improve the fundamentally patient-reported experiences and outcome of care. We think that by improving that change package, by improving timely access to care, by involving children and young people, and by being coached in quality improvement, we will be supported to deliver a really sort of impactful change package, something that works locally, but of course can be shared and we can all learn from nationally. And there's a couple of links there on the slides, and I'm sure we'll be able to make these slides available at the end. What's going to be really critical is that teams, when they apply, need to identify a team lead. Anybody across the MDT, but someone with enthusiasm to lead your local team. And of course, because of we are going to be having learning events face to face, really important that teams do get some local management support. Final slide, thanks Nick. Application is an online application through the BSR website. Deadline is the 4th of July. We're planning to let teams know by the end of July, and then of course we'll get kick-started with the learning event in Brighton. So we really hope that teams are able to apply and to join. We hope that the application process will be very competitive. There are going to be six teams successful. Good luck. Please reach out at the end of the webinar or during the course through the chat or later if you have any other questions at all. And I'm going to hand over now to Debbie Wilson, who's the Young Persons Project Manager at NRAS? Thanks, Debbie.
Hi Gavin, hi everyone. I'm hoping my voice will hold out. I wasn't too well last week, but hopefully it will be fine. As Gavin says, I'm Debbie Wilson. Generally I come to these sort of things with, slides gone, with three hats on. I have JIA, I'm a JIA patient. I also have a child with JIA, and as Gavin says, I manage JIA at NRAS. Next slide, please. Just a brief background on me. I was diagnosed with JIA around 8 years old. That's many, many years ago now. It did take quite a few years to get a diagnosis. Even when I did get the diagnosis, I was never given any treatment, just short-term steroids. And you will know that teenagers and steroids are never a good mix. It spread throughout my body, throughout my childhood. I was never given any support or information, and all I was ever told by doctors was just get on with it. And as a child, you have no choice, you have to, and I suppose if anything, it kind of give me the resilience to actually learn to adapt in life, and that was never more prevalent to, next slide please, to when my daughter got diagnosed with JIA. Thankfully by this point I was on biologics, and I was actually on medication because in my adulthood it spread to my eyes. I have scleritis, and along with lots of other joints as well. I do have damage in some of my joints, but thankfully my daughter doesn't at the moment. She was straight away put on methotrexate, which unfortunately didn't then work for her, but now she's on a biologic as well. And you know, things, fingers crossed, seems to be working well. But as you all know, with JIA, it is learning to cope with the flares, everything that comes along with this disease. It's not just arthritis, it really impacts on everything, you know, throughout life. And looking back, you know, some things have changed from my diagnosis to my daughter's. You know, the services are so much better. You have the multidisciplinary teams. I never had that. You know, you have the physios, the podiatrists, everyone, you know, and everyone is all equal in that team. It's not just all about the medication, it's everything that goes with it. It's learning to manage it. And the treatment is so much better than it ever has been. And, you know, there's going to obviously more research going on as well. And the outcomes for children are so much better if they get the diagnosis quickly. I was even talking to parents last night, and they were saying their GPs would just kept turning them away. They kept saying it is growing pains, and it's not. And they have that diagnosis now, and now they're having to have the steroid injections and going on to the methotrexate. It's hard for families to actually turn up to doctors and say, no, there is something wrong. What is this? And it's not until you get the diagnosis that actually the treatment does work. Next slide, please. So as I said, there has been some amazing changes throughout, you know, my generation, but there are still things that needs to be done. It can still take a long time to get a diagnosis. Postcode lottery on care, you know, some of the teams have everyone, which is amazing, but others don't. So why is that? We all pay in the same. It should all be the same. We all need the consistent information and the support for families out there. Even trying to get the methotrexate and the DMARD prescriptions, it's not equal throughout. Even for me, I had to battle with my local hospital to get my child's prescription because the GP wouldn't do it. And it's just kind of putting the family in that position where you're kind of piggy in the middle, and it shouldn't be right. We need to prepare children and, you know, young people for the adult services. It's so different to how it is pediatric, and access to the teams in a timely manner. You know, sometimes we might not need, you know, I think it's PIFU, you know, what Gavin has been talking about on the Facebook Live that we did. You know, sometimes we don't need that follow-up appointment straight away, you know, but we might need the urgent care. So again, that all needs to be sort of straightforward and consistent throughout all the teams. Next slide, please. So it's just a very quick rundown from me, and it's kind of why, really. We are all here to help kids with JIA. That's why we're all here. This is why we all work. But if we improve services, we really do improve lives, and we still need kids to be kids. We still need them to have the childhood that every child should deserve, and JIA shouldn't stop them. So, you know, if we really do help us to help you to really improve, it will really improve children's lives. So thank you. That's a quick rundown from me. And I think it's great that this is in my first ever JIA Awareness Week. So thank you so much. And I'm now going to pass over to Catherine Wright from Northern Ireland VA.
Hi, thanks, Debbie. So what I'm going to tell you about is a little bit from me, really. So similarly to Debbie, I was diagnosed with JIA and uveitis whenever I was 2, which is a long time ago. So I'm kind of flying that flag, but also I work with Versus Arthritis in the Young People and Families team. So I work really closely with the Belfast Paediatric Rheumatology team. And myself and some of the other charities, so Debbie and Emily from CCAA and Sharon from SNAC and Richard from JAR, kind of got together with a bit of a wish list that came straight from children and young people of what would be, you know, really good in terms of service improvement from the ground. So I'm just going to talk you through that kind of slight wish list of ideas. Some centres, as we know, there is disparity across the UK in terms of what's on offer for children and young people when diagnosed with arthritis. But some of these ideas, and we've split them into kind of 3 areas, so paper-based ideas, tech ideas, and then kind of in-person. And some of these things will happen in some centres and some won't. And the brilliant idea, I think, of this project is that if they do happen in one centre and it's successful, we can share that learning and share that knowledge relatively easily across the UK. And ultimately, what we want to do is improve services for children and young people. So next slide, and I'll quickly fly through our kind of ideas list, and hopefully some of these will resonate with you. So in terms of the paper-based ideas, some of the things that we all know when we had our kind of quick meeting before this from talking to children and young people, things that would make a direct impact for them. Newly diagnosed packs, they're relatively easily to do with helpful tips, who to contact when your child flares, how do you know if it's a flare or something else. That sort of idea could be really useful within centres. Joint roadmap for support in local areas and kind of linking up initiatives as well. Simple, helpful resources for children, young people around medication, mental health, general coping, what to expect from your diagnosis, what to expect from the move to adult services. Standardised advice on folic acid was something that came up quite regularly because it seems to be a bit difficult to kind of get that across teams. Rollout of individual healthcare plans. I mean, these are ready to go. They can be used already now, and they would have a real impact for children and young people in terms of issues with schools. Again, what to do if your child flares, a simple leaflet. Impact of a youth worker on teams. Some centres have youth workers, some centres don't. What's the impact of that in terms of the children and young people? What do they say? Hospital passports, again, we thought they could be a really useful addition for children and young people, like a red book insert. In terms of adult teams, we feel there's a bit of disparity in terms of adult teams actually understanding what JIA is and having that knowledge when the patients move into their services. Schools, toolkits, information for PE departments, again, that's a big thing. A lot of kids feedback that they're kept out of PE and physical kind of education in schools, and that's a real problem for them. And then also blood results explained as well. And so those are some of our ideas in terms of the paper-based stuff. So next slide, please. In terms of tech-based, we thought, you know, access is all you know, really important for children and young people. So making forms easier, getting rid of paper-based stuff at times. I mean, some people like paper-based stuff, but in order for young people to, you know, be able to access certain forms, I don't know about your centres, but in Belfast, there can be a bit of sitting about. So get people to access things digitally, like Ready, Steady, Goes or the CHAC forms that people fill in. Proms and prems, all of that could be done again if people are interested in some kind of tech-based ideas for this project. That could all be done through an app. QR codes with FAQs for parents, again, could be really useful. And case studies recorded of patient journeys to show others when appropriate if they're at that stage in their journey as well. So those were some of the tech-based ideas. And then last slide. Nick, please, thank you. So the in-person based ideas are, and I know some centres do newly diagnosed kind of virtual sessions that can last for about an hour and a half. These have been really useful in those centres. I think it's Evelina that does that. You know, why can't they be rolled out for other patients that are accessing services at different clinics? Some greater support for the move from peds to adult care session for both the young people and their parents, because both those are very important. Training up teams of parents who have knowledge and skills and tips to share, because whenever I work with parents, and I know some of the other charity groups say this too, they want to talk to other parents. They don't really want to talk to a health professional about their kid's diagnosis. They want to talk to another parent who's been there, seen it, chases their kid around the house on a Friday night with methotrexate and knows how to deal with that. You know, that's the type of information that they want. Sessions on medication, psychological support, sleep, fatigue, an adulting event that we run in Northern Ireland covering the importance of kind of good, honest communication with teams. We also thought about co-led charity events, day events, seminars, specific topic issues, and team residentials could be quite good. Training some of the language within teams when talking about the move to adult services. That might be quite an interesting project to do as well. Improving access to the clinical team, ability to book slots for phone appointments and late clinic offers. I don't know how many kids tell me that they get a letter to say they're having a phone appointment between 9 and 12, or it's going to be at 10 o'clock, and they don't know, they can't answer the phone in class. So invariably their parents are picking up those calls, and it's not ideal sometimes. There's bound to be an easier solution for this. Adolescent young adult clinics, and again, I know some services run that, but some don't. And they're very beneficial if they could be run more across the board. Run regular focus groups and involvement sessions. And I suppose for us in the charity groups, this is key. We talk to service users all the time, and I think sometimes it's a surprise that centres don't do as much of that as they could do in terms of talking to their patients and finding out what ideas might be ideal to run forward. Methotrexate sessions, running those a few times a year. They could be pre-recorded, but they could be really helpful resource for young people and parents who are starting that, and obviously that could be run through for biologics as well, and steroids. So those are some of our ideas. I'm sure some of you have already thought of those, but we just thought it might be helpful today to kind of run through those. Like I've said, I think the key is talking to your patients, and I know it's quite a kind of short time frame when the deadline's the 4th of July, but it's relatively easy to do. And if you're talking to them and coming at it from a genuine place of, we really want to improve services for you, you know, you won't be able to get them to shut up about the things that they, you know, the ideas they'll have. So I'm not sure who I'm handing over to. I think it's just back to Flora and Gavin, is it?
It's back to me. Back to me as your compare without compare. Thank you so much,
Nina.
Thanks Debbie, thanks Catherine, Anna, Flora, Gavin, and thank you all for listening. Shall I open the floor to questions, and then the relevant person can answer? So I'll leave it to kind of our faculty to work out who that is. So Ruth.
Sorry, I apologise. I did join the meeting late, but I'm one of the lead nurses for rheumatology in Newcastle. And one of the things I just wanted to raise, perhaps should be on your radar, is that I've noticed over the last 20 years that the workforce in specialist nursing for rheumatology is very fluid. And you don't see that in other specialties. So, for example, my colleagues that are in renal or neuro, they seem to be more static. So just wonder, one of the key things that you should be looking at is why is the retention of specialist nurses in rheumatology not, that doesn't have the same longevity? Because a lot of the issues that you've just been raising as from the charities, if I use that collectively, that communication and an interface, that very much the first port of call for a lot of those issues are the specialist nursing team. If you haven't got nurses with the wealth of experience that perhaps I have got, or somebody who's been in the job for 10 years, you've got somebody who's only been there for a couple of years, that is going to reflect. So I think it would be really useful to include workforce and what is the retention and recruitment, particularly specialist nurses, because I am quite staggered at how fluid that workforce is compared to other specialties.
Brilliant. Thank you so much, Ruth. It's Anna here, and Gavin's going to kind of come on in. But I think one of the things that we know from Breakthrough Series collaboratives that cover other areas is that inevitably over the course of the time that we're together, there'll be huge issues that come up like workforce, that we can actually use our power to come together to say this is an issue. Now, we might not be able to fix some of that together, but we can raise it as a strategic and operational issue, and we can act as a bit of a sounding board for these are some of the key things that we're finding are barriers to doing some of this improvement work. So I'm going to hand over to Gavin, but that's my initial reaction to that one based on what I know has happened in other Breakthrough Series collaboratives, because you're absolutely right, workforce is always key to this, absolutely.
Yeah, it really was going to reflect very similar themes. Thanks, Ruth. Points really well made. Yeah, how can we deliver improved outcomes and experience of care without the right workforce? Yeah, and then feeding into that sort of the concept of timely access to care and how that care is delivered. So I would be completely appropriate, to build that theme into the collaborative. Thank you, Flora.
But just to say, Ruth, I think maybe you were thinking about coming to BSPA. We're hoping at BSPA, Nina will maybe touch on this as well, to have a bit of a session discussing the various different pieces of work that are all sort of in this arena at the moment, because there's a few different things going on that might equally be able to contribute to a better understanding in this area.
Yeah, absolutely. So I think my colleague Sarah, who is on the call, will be at BSPA. So I don't know, we probably don't have enough time to kind of expand on that today, but let's see how we get on, and if we want to, we can do, and I'll pick on Sarah to come on later. Ethan?
Yeah, thanks. Yeah, great presentations, everyone, and this is a fantastic idea. And I really like the idea of different centres taking up slightly different projects and then sharing it all at the end. So my question, I suppose, concern in a way is, although it's a national health service, as people have said, it's almost a postcode lottery. Every centre, every team works differently, and I really want to find out how will we have the power at the end of 18 months to say, if this idea really works in one centre, how can we force it through other trusts, or how can we say this, we want primary care to recognise JIA better, how can we get all the primary care teams across the country actually to work together? Because there's always barriers, even sharing patient information leaflets between different centres have to go through individual trust policy groups, etc. Is there a way that we can fast track the changes through, because it's gone through this process?
Thanks, Ethan. I will defer to Flora here, who had her hand up, but great question.
It's a brilliant question, a really important one, Ethan. I think that we talked about this quite a bit when we met in Glasgow, and a few of us had really good suggestions, including Rachel Tattersall, who pointed out that what we should be trying to do is identify areas to work on that are already identified as priorities for trusts. Or trusts' strategic visions and priorities are incredibly similar when you stop and look at them. So if we can make what we're doing kind of shoehorn it into there, that's probably the best way to make our projects visible and accessible to trusts. And the other thing is that at the end of this, our ambition is to post what we've learned and what we know on the BSR website, so that it's there and available for everyone to use at a kind of nationally supported level.
Anna? Oh, you're on mute.
Sorry. It's an incredibly important point, and I think one of the things that we'll do as a collaborative is work together to think about what sustainable legacy do we want to leave at the end of the collaborative. So that will be in our minds right from the very beginning, and there'll be certain things that we might be able to do through influencing. There'll be certain things we might be able to do by sharing our data and showing that when we've worked together, we've reduced that variation, or that we've got fantastic feedback from children and young people, for instance, on some of the things that we're doing. So tactically, we'll definitely include that. And I can't promise that it will lead to other things, but in other breakthrough series collaboratives, it has then influenced maybe adoption of wider spread national or regional work around this, because we've broken the ground. Because actually at the moment, it's really hard, isn't it, to be able to kind of have the data to show that there's so much variation going on. So I think one of the things that's key to this is all kind of pulling together to say what is really important in JIA and what do we think these standards should be. So there's something about how we can collectively influence going forward too after this. It's really important.
Thanks, Anna. And I think there's something to be said about, as BSR are the sponsors of this programme, we do have a leadership voice within paediatric and adolescent rheumatology care. So we are doing work at a strategic level, pulling some of these things together and making sure that anything that we do and anything that we produce from the work that we do is aligned to kind of the national drivers, and there is some sort of infrastructure to be able to replicate and not duplicate. So hopefully that will all come together. Kirsty?
Hi, sorry, I got here late and I've now discovered that my dictaphone will actually act as a microphone, but I don't have a camera. Apologies for this, and I hope it's working as a microphone. Just a comment before about how do we get the work done recognised. And I know on the BSR you've got your quality assurance, quality review scheme, and there's talk there about get your trust accredited with the fact that you've been through this process, and I get the impression that's an adult setting. So would the same apply to the paediatric QI work, that the gong to the trust is that you've done this work, now you've got a quality accreditation, and to share and to make it a high value item that the trust may be interested in to implement to do what Ethan was suggesting?
So I can probably take that question. So the QRS is indeed focusing on adult services at the moment. So we're redeveloping and relaunching later this autumn, initially focusing on the adult sector, mainly because there is so much exciting and innovative work happening within paediatric and adolescent care that actually we felt that we need a bit of time for that to embed and settle before we then introduce another programme of work, or kind of a complementary programme of work. However, that being said, there is it is I've lost my words. We do intend to expand the QRS to paediatric services as well in the future, so kind of watch out for that. In terms of I suppose we could look at as a programme of how we can acknowledge the services that have been involved in the programme, and what that looks like in terms of, you know, communication collateral, but also something about the work that's been done. Flora, can I pass on to you? And Anna, you did kind of do a bit of that, but I'm not sure whether I covered that for you.
It was just a very quick comment, Kirsty, that I think almost all trusts now have a quality improvement lead at senior exec level. So I would suggest, as well as kind of getting your local, you know, directorate manager involved in this, it might be worth reaching out to them right at the beginning of the project, so that what you're doing is visible to and aligned with, obviously, your own management team.
Yeah. Emily?
Hi everybody, I'm from CCAA with arthritis. Sorry, I can't access the chat, so I can't actually put my name in there, but I am here. It's really exciting to be involved in this project. There's quite a few of us charities on the steering group, and we're just thrilled to have the opportunity to be involved in something like this that's really led from patients and families. And I think that's just what I wanted to put in here today. There's so many amazing ideas that we'd had come from young people and families. I think I'm aware, listening to it from a new sort of fresh pair of eyes, that it can be a bit overwhelming to think where to even start. And so I guess I just wanted to leave with you that if you're not sure, just ask your patients this week. You haven't got very long, I know. Just ask when they come in, what would make the biggest difference to you in how we look after you? What is causing you issues this week? What could we do better? What could we do differently? And if any centres need help in that process, you know, lots of us charity representatives have contacts across the UK with key parents and patients in our areas, so we can help you make those links very, very quickly if you just wanted to do a quick straw poll. But I really would urge and encourage you to start from that perspective rather than from what do we think will make a difference, because I think the things that are going to have the longest and the biggest impact on outcomes will be those things that matter to children and families themselves. Thank you.
Fantastic. Thanks, Emily. That's actually a really great way to end and summarise. Anna, I'll pass on to you, and then if you wouldn't mind passing back to me for the last 30 seconds to finish up, that would be great.
I just wanted to say, totally agree, Emily, and we would really welcome every team that applies thinking about how could they have a local kind of connection with their children and young people. For us, that co-production is really important. And I echo the fact that many clinicians in the room never get any training on how to do working with children and young people in a co-production way well. So we're going to include that in the learning events, and we're also going to train you all in how to do QI. So there's going to be a legacy for you as clinicians too, in terms of your skills and capabilities that you'll get from coming on board, hopefully. So I'm going to say nothing else, and I'm going to pass over to Nina to close the session for today. But thank you everyone for joining us. It's been wonderful to hear your questions.
Thank you so much, Anna. It is 1:45, so Lorraine, if you pop it in the chat, then we can respond to you. So thank you so much for everybody coming today. I hope you've got what you wanted to get out of it today. We're so happy to see so many people on the call. In the chat, I'm going to put the contact email address that you can contact the team if you've got any questions. I'm going to put the link to the application form for Teams. But just before we close today, I just wanted to get a very quick straw poll of everybody on the call using your little yellow digital hands. How many people on the call are from services or teams that are hoping to apply to join the collaborative? I'm not going to hold you to it. You can have a look at the application form first, but just fantastic. Obviously, some of you might be from the same service, so that's fine. Great. So a question just there to finish with, do you need a specific project? So no, you don't. There is a question on the application form about potential projects you might have, which you can put some information on, but again, you won't be held to that, and it's all about development within the sessions and the learning events. I will bring the webinar to official close and send this, but if anyone wants to stay on and there's more questions, then I'm happy to stay on and answer. But I just want to make sure that people get the information they need. There you go. Thank you, everybody. Great. So I'm going to take some of the questions now, because I think we've got some more questions. Was someone asking a question there?
Nina, is it worth me just responding to Emily's question about the projects as well, and just explaining a bit? So what we're going to do in the collaborative is, at the moment, we're thinking we'll focus on about improvement ideas under those three big headings that Gavin kind of explained. We'll come together, we'll agree which ones we're going to kind of work on together, and then you'll test them out in your locality. So that will all happen in Learning Event 1, and we'll be in touch with the selected teams ahead of time to get you ready for Learning Event 1 too. So you're not just coming to there knowing nothing. We'll get you ready so that you're kind of properly kind of onboarded and really excited about joining us then. Hope that explains it.
Thanks, Anna. Fantastic. So those hands up are probably legacy hands from asking who wants to be involved. Anyone who doesn't have any further questions, I will let you go and have a wonderful afternoon, and thank you so much. And anyone who has any further questions that you want to have a quick chat, I'm happy to stay on for a bit longer. The faculty, obviously, whoever wants to stay on can stay on, but also you can go off and have a wonderful afternoon as well. Thank you. if anyone is staying on to ask questions, feel free to just ask now.
Hi, sorry, it's Lorraine Cosgrove. I couldn't actually put